All right, so this chapter is on the peripheral nervous system, which is all the nerves that come off the brain. We call those cranial nerves. Remember, we have 12 of those, and all the nerves that come off the spinal cord. So we're going to walk through just kind of the structure of our nerves. What do they look like? We'll also talk about how we classify nerves and how a nerve can regenerate. And then we'll go through our cranial nerves and our spinal nerves. I am not going to go through all these spinal reflexes. They're in your textbook. I will probably talk about maybe one of these spinal reflexes, but the rest of these, I may ask you a bonus question on one of these. So you may want to kind of read through your book about the reflexes. It's just different kinds of reflexes. So the peripheral nervous system, like I mentioned, this is all the nerves outside the brain and spinal cord. Okay? Everything that comes off the brain and everything that comes off the spinal cord. And we divide it, remember when we're talking about the nervous system, we divide it into sensory and motor. That determines what way information is traveling, right? If it's sensory, it's going towards the brain. If it's motor, it's leaving the brain. Okay? So same thing with nerves. And nerves are sort of these cord-like organs. Usually they follow the same path as blood vessels. And they look in terms of how they're enclosed. They're enclosed in connective tissues, and they look very similar to the way muscles are also enclosed. And so the connective tissue coverings are the endoneurium, the perineurium, and the epineurium. So that should look really familiar. Remember when we look at muscles, we have an endomysium, a paramysium, and an epimysium. The difference here is instead of using the term mice for muscle, we use the term neurium for nerve, right? So it's kind of the same concept. Let's look at this picture and talk about these three coverings. So we're going to start deep inside. This is one nerve. We're going to look deep inside. Here's an axon. Okay, way up here. There's a little axon. You can see it's myelinated, so we can see those little bubbles on there. This covering, this yellow covering around that axon is the endoneurium. Endo means inside, right? And just like with muscles, remember how muscle cells are arranged in fascicles? Same thing with nerves. You get a lot of axons grouped together, arranged in a fascicle, and surrounding that fascicle is the perineurium. Remember, peri means around, so it goes around the fascicle. And then all those fascicles are grouped together, and they're all held together by that connective tissue called the epineurium. Epi means above or on top. Okay. So it's just like our muscles. We just call it neurium instead of mysium. Now, our nerves can regenerate, but damage to nervous tissue is always really serious. Because remember, mature neurons are amitotic, which means they can't divide. They can't go through mitosis. That qualifier A means not. Okay? So if the soma is the cell body, is damaged, then that nerve cannot regenerate. But if the soma remains intact, the cell body is intact, then the damage can be repaired. So really what this means is, let's say if we're looking at a neuron, and I think I mentioned this in the last chapter, where maybe the axon has been damaged, but the cell body stays intact, as long as this biosynthetic reaction center of the cell stays intact, it can regenerate a process, okay? But if that cell body, if that soma's been damaged, you're out of luck, okay? And so in order to regenerate a process, there's three things that you have to have. You have to have macrophages. Macrophages are a type of cell we'll talk about in AP2. They're part of your immune system. Their big job is to clean up debris. They're like little trash cans. You have them in your lungs. They clean up little particles in your lungs. You're going to find them all over the body, and they just pick up debris, clean up the area. You also have to have Schwann cells. Now remember, what do those do normally? What do they make? Yeah, they make the myelin sheath, right? So remember, Schwann cells are a type of neuroglia, glial cell, a supporting cell. They normally make the myelin sheath. In this case, when you've damaged a process like an axon, the Schwann cell forms something called a regeneration tube. And that way, that neuron knows what way that axon should grow, how it should repair, in what direction. And then axons have to regenerate. Okay? So if we look at a picture of this process, this is the same thing that's in your book. You can see this yellow axon's been damaged, right? You see all these little parts and pieces of the axon here. So the first thing that has to happen is macrophages come in. That's these purple guys. And they're going to gobble up all the debris. They're going to gobble up all the little pieces of the axon, little myelin droplets. They just get rid of all of that. Clean it up. Once it's nice and clean, this axon will start to regenerate. And it does it. It knows what way to grow because of this regeneration tube that those Schwann cells have formed. So that axon regenerates. And you can see that it forms this single filament. And at first, it's really small. Do y'all remember in chapter 11 we talked about transmission, nervous transmission? Which way is faster? Myelinated axons or unmyelinated? Myelinated. Which way is faster? Big fat axons or skinny small axons? Big fat ones. And so initially what happens when this axon regenerates is it's kind of small. And so you're still going to have nervous transmission. It's just going to be a little bit slower. And over time, this axon will beef back up and get bigger, so transmission gets more effective. Okay. Now, we classify our nerves based on the signal we're sending and what direction it's going. Is it going towards the brain? Then it's sensory. It's going away from the brain? Then it's motor. And so we say that afferent impulses, afferent, I remember the A for approach. So this is carrying an impulse to the brain and spinal cord. So would that be sensory or motor? Sensory. Efferent. E for exit. It's carrying impulses away from the brain and spinal cord. So would that be sensory or motor? Motor. And then we also have something called an interneuron. These do both. These are going to carry impulses towards the brain and away from the brain. These are the most common type of nerve that we have. They can do both. The nerves that come off the brain are always called cranial nerves, and the ones that come off the spine are called spinal nerves. Okay, so we're going to go through some cranial nerves. Now we did these in lab. And I gave you that saying, on occasion our trusty truck acts funny, very good vehicle anyhow. But the saying that's used in your book and in the lab manual is this one. Oh, once one takes the anatomy final, very good vacations are happening. And then the first letter of each of these represents the first letter of that cranial nerve. So remember, your cranial nerves have a name and a number, so we can number these. We have 12 cranial nerves. They're paired, so you have one on the right and one on the left for each of these. Okay? And one thing to know and remember about your cranial nerves is that because they're coming off the brain, your cranial nerves are mostly just going to the head and the neck. Okay? The exception to that is the vagus nerve. Remember, what does vagus mean? wanderer, the wanderer. So the vagus nerve is the wandering nerve. It actually extends, this is the one that goes down and goes to the heart and your intestines and your bladder and all those internal organs. Here's that other saying that I gave you, so you have that one as well. So each cranial nerve is given a name and a number, but we also know that our cranial nerves can either be sensory, they can be motor, or they can do both. And so there's another saying, we put it together with this first one that I wrote on the board, and it is right here. Some say marry money, but my brother believes it's bad business to marry money. So I'm going to write that next to this. Some say marry money, but my brother believes it's bad business to marry money. Okay, so those two sayings kind of go together. The first letter here tells you if it's sensory, if it's motor, or if that nerve does both sensory and motor. Okay? So this is super helpful when you're studying for Monday because you can now kind of figure out, okay, here's my 12 cranial nerves, here's my saying, write my saying down, here's my 12 cranial nerves, and then write the next saying down, and that'll tell you, oh, that's sensory, or that's motor, or that does both. Because there's going to be questions on your exam where I'll say, which of the following cranial nerves is a solely sensory nerve? And I might have a couple on there, but if you've written this down and you can remember those nerves, then you can really quickly figure out, okay, which one is sensory. Okay? So these sayings are pretty helpful. Now remember in lab, I told you that for our 12 cranial nerves, we kind of start at the top and work our way down pretty much in order. The only one that's out of order is that very last one. So remember our first cranial nerve, it starts with an O, that's the olfactory nerve. This one is a sensory nerve, and it's picking up the sense of smell. Right? The next cranial nerve is right here. This is the optic nerve, cranial nerve number 2. This one is also a sensory nerve. It's picking up sight. The oculomotor nerve is number 3. This one tells you in the name, motor. So this is a motor nerve. And it is helping direct eye movement. Number 4, again, we're just kind of walking our way down, is the trochlear nerve. The trochlear nerve is also a motor nerve. It also directs eye movement. This big one, the next one, is the trigeminal nerve. I remember that one because I remember tri for 3. And this one actually, it's really fat at the base of the brain because as it moves away from the brain, it branches into 3 branches. Okay. We also have, the next one is here. This is the abducens nerve. This is an eye movement nerve as well. If we keep going, we have our facial nerve. We're just walking our way down. Then our vestibulocochlear nerve. Our glossopharyngeal. Vagus, that's that wandering nerve. Cranial nerve 11 is the accessory nerve. This one kind of hits your neck structures. Okay, goes to those muscles in the neck. And the last one, the only one that's out of order, is here, number 12. And number 12 is the hypoglossal nerve. Okay, so I'm going to go through each of these 12 cranial nerves, and we're going to talk about what they do. Okay. So I told you the very first one is the olfactory nerve. This one picks up the sense of smell. It's solely a sensory nerve. This is the one where, remember, we looked at some of the bone markings of the skull, and you looked at the cribriform plate and the crista galli. So the cribriform plate has little holes in it that we call olfactory foramen in them, and the crista galli kind of sticks up in between. So the crista galli, that hump, is actually separating the olfactory nerves. And then those little olfactory foramina in the cribriform plate let these little nerve roots go down into the nose to pick up the sense of smell. So this is a sensory nerve. So let me go back. What you're actually looking at here, that I keep calling the olfactory nerve, is actually the olfactory bulb. It's this really big, fat, flat structure. The olfactory nerves are what are actually going through that cribriform plate, through those olfactory foramina. Cranial nerve number 2 is the optic nerve. This is also a sensory nerve, and it's picking up sight information. So this is going to take information from the retinas and send it back to your brain to be processed. And we'll talk about sight in the next chapter, in chapter 15. The oculomotor nerve, this one tells you what it's doing in the name, right? It's a motor nerve, and oculo means eye. So this is a motor nerve, it's involved in eye movement. You will also be looking at the eye in the lab next week. We'll also do it in the lecture in chapter 15. The eye itself has 6 muscles around it. We call them extrinsic eye muscles. And they can help to raise your eyes, lower your eyes, turn them right and left, diagonal, all over the place. And so the oculomotor nerve controls 4 out of the 6 extrinsic eye muscles. So you can see from this picture, you can see some of those red eye muscles. This nerve innervates 4 of those. It also does other things. Helps to raise and lower your eyelids. It also helps to constrict the size of your pupil. Okay. Cranial nerve number 4. This is our trochlear nerve, and you can see it is a motor nerve. So the trochlear nerve is also involved in eye movement, but this is going to, out of those 6 muscles, this is going to go to 1 of those eye muscles. And it actually goes to this one at the very top. It's called the superior oblique muscle. This one gets its name because the tendon that connects the superior oblique muscle on the eye looks like a pulley. Now, y'all know what a pulley looks like. And so the term trochlea means pulley. And so this is why we call it the trochlear nerve. So this is also involved in eye movement. Cranial nerve number 5 is the trigeminal nerve. Remember, this is, I remember a tri for 3. This is the first nerve that we've talked about that does both sensory and motor function. You can see here the trigeminal nerve, and you can see it branches into 3 big branches. It's going to go out to all these areas of the face. Now, you all did bone markings on the facial bones. You learned bone markings like mental foramen, infraorbital foramen, supraorbital foramen. All of those holes are there to allow passage of things like nerves, trigeminal nerve. So this is going to go out to all the areas of your face to pick up sensation in the face, right? Like my son likes it when I just kind of like, he loves like his eyebrows rubbed. It's so weird. He'll be like, can you rub my eyebrows? He's bougie. He'll like rub his eyebrows. Yes, baby, let me rub your eyebrows. So he loves like his face being touched, right? Because it feels good. You have this trigeminal nerve that helps with that. The motor part is that it also goes to some of the muscles like the masseter muscle, that big muscle in your jaw that helps with chewing. Okay, so it's motor and sensory. The next nerve, number 6, this is the abducens nerve. This one is a motor nerve, right? And this one, remember, we've got 6 extrinsic eye muscles. 4 the oculomotor nerve goes to. 1 the trochlear nerve goes to. The last one, the 6th one, the abducens nerve goes to. You can see this nerve comes up and it hits this muscle right here on the very outside of the eye. We call it the lateral rectus muscle. And if that muscle contracts, it's going to pull your eyes out to the side, And anytime you pull anything away from your midline, like your legs or your arms or your eyes, we call that abduction. So that's how this one gets its name, the abducens nerve. The facial nerve, cranial nerve number 7, this is a mixed nerve. It does both sensory and motor. The motor part of this nerve, you'll see that it's also going out to all these areas of the face, but instead of going out to the skin and giving you sensation, it's going out to the muscles of the face to provide you with movement. So it gives you facial expression. Lift your eyebrows, flare your nostrils, smile. The sensory part is that it goes to your tongue and it picks up the sensation of taste. Now there is a condition called Bell's palsy. Does anybody know anyone who has had Bell's palsy? Bell's palsy is caused by inflammation of the facial nerve, which is caused by the herpes virus, herpes simplex 1. There's lots of different simplex, yes. This is not the genital herpes. This is not the STD herpes. It is cold sores. And so if somebody has herpes simplex 1, herpes is, if I can explain this, herpes, the virus, is sort of like glitter, right? Like I have started learning to make those glitter tumblers, like the Yeti cups, and you epoxy them, like trying to learn how to make those. And so my husband has this huge like wood shop in our basement, and so I've taken up his big area, and there's glitter everywhere. And my husband's like, oh my God, he hates glitter. Because glitter, you know, even if I clean it up and it's all gone and you don't see it, 6 months from now, my husband's going to come upstairs and he's going to have a piece of glitter in his beard, right? Or my son's going to have like glitter over here on his eyeball or on his lip. Like it never goes away. That is herpes. So think of herpes as sort of like the glitter of viruses, right? Like once you have it, you got it for good and it is never going to go away. It will just randomly reappear. So it's the same with like cold sores or the herpes simplex 2, which is STD virus. What happens is it gets in your body, it evades your immune system, and it hangs out. And then when your immune system is lowered or you're immunocompromised, maybe you're sick, maybe you're stressed, then herpes can kind of come out with a vengeance and you'll get a cold sore. And so Bell's palsy is when this herpes virus actually causes the facial nerve to become swollen and inflamed. And when that happens, all of that extra pressure actually causes the nerve to not function correctly. And so you'll get like facial droop. Usually it's on one side of the face. You might not be able to close your eyelid all the way. Any muscle that facial nerve is going to can be affected until the swelling goes back down. So it does go away. It just sometimes takes a while.
So Bell's palsy is caused by a type of person.
Yes. Yep. The next one that I'll mention, cranial nerve number 8, is the vestibulocochlear nerve. This is a mixed nerve, so it does both sensory and motor. If you look at the name of this, and I know we haven't done this in lab yet, we'll do the ear next Monday. The vestibule is an area in your inner ear. And the cochlea is also in the inner ear. It helps you hear. So the vestibule helps with balance. This is, you've got fluid in your ears. So like I remember as a kid, we would like spin in circles and then we'd stop and be like, whoa, we're so busy. This is what we did. When your mom kicks you out after breakfast and says don't come back until dinner time, this is what you do outside. So the vestibule is that fluid in your ear that helps with balance, right? The cochlea is the area of your ear that helps with hearing. And so obviously this nerve, vestibulocochlear, it's a mixed nerve, so it's going to do both of those. It is going to help with equilibrium, so balance, and hearing. So the name kind of tells you that. Now, it is considered a mixed nerve by your textbook. It says that the motor part of this is that you can adjust sensory receptors in the cochlea to help you hear better. So nothing you can see, but there is that motor part. Cranial nerve number 9 is the glossopharyngeal nerve. What does glossus mean? tongue. And how about pharyngeal? Yeah, pharynx. Where's your pharynx? Back of your throat, right? So this is a mixed nerve. The motor part is that it goes to your tongue and your pharynx, right? So it's going to help with things like speech and swallowing and chewing. The sensory part is that it's going to go to your tongue for taste also. So it helps with taste. The next nerve, cranial nerve number 10, is the vagus nerve. This is, remember, the wanderer. And so this one is a mixed nerve. It's the only cranial nerve that goes beyond the head and the neck. This one is going to go to all of these internal organs, right? The liver, the stomach, the kidneys, the intestines, the pancreas, the heart, the lungs, all of those. And so the motor part is that it goes to all those visceral organs. The sensory part is that it does go to your tongue for taste. So I mentioned this in lab, but this is how someone can have a completely severed spinal cord. So they have no motion below that area where the spinal cord's been severed, yet their heart can still beat. They can still digest their food, right? Their liver still functions. All of those functions still work. Cranial nerve number 11 is the accessory nerve. I always remember earrings. That's always what I think of. So earrings are accessories. This one, if we look at it coming off the spinal cord here, it looks kind of like a dangly pair of earrings. And so this is a motor nerve. This is going to hit all of the muscles around the neck. So it's going to go to like the sternocleidomastoid and the trapezius muscle and the platysma muscle. So all these muscles in the neck. And then the very last one, number 12, is the hypoglossal nerve. This one has glossus in the name, so we know it's going to the tongue. It is a motor nerve. And so this one goes to the extrinsic and intrinsic muscles of the tongue, so it helps with swallowing and speech. Okay. So notice, again, all 12 of these cranial nerves are going basically to the head and the neck. The only exception to that is the vagus nerve, the wanderer. So for your test on Monday, you know, if you can remember both of these things, you put them together. That helps a lot. And then sometimes the name of these will give a lot away, right? Like if you know it has glossus in the name, you know it's going somewhere to the tongue, right? Oculomotor, if it has oculo in it, you know it's the eye. So kind of be aware of the name. That helps a lot as you're studying. So we're doing the peripheral nervous system, right? And we just did cranial nerves. So the other kind of nerves that we have are spinal nerves. They come off the spinal cord. We have 31 pairs of mixed spinal nerves that are coming off the spinal cord. Notice this term. All of your spinal nerves do both sensory and motor function. They are mixed. So cranial nerves can be sensory, motor, or both, but spinal nerves are only both. They only do both sensory and motor. And spinal nerves don't have all those complicated names. We just name them for their point of origin. So we have 8 cervical spinal nerves, C1 through C8, 12 thoracic, T1 through T12, 5 lumbar, 5 sacral, and 1 from the coccyx. Which one of these does not match the number of vertebrae? Yeah, how many cervical vertebrae are there? 7, but there's 8 cervical spinal nerves. The reason is because we typically start counting our spinal nerves from below where they come out from. So like normally it would be like the first one comes out below C1. But in this case we have an extra one in the cervical region because you do have one that comes out above C1 as well. Okay, so there's one extra in there. So these are the spinal nerves. You looked at these in lab when you looked at the flat man model. Okay, so you can see all the way from C1 all the way down to that coccyx, that coccygeal nerve. And they're paired on the right and on the left. Each spinal nerve connects to your spinal cord by roots. We call these medial roots. And there are little rootlets that attach to the spinal cord. So I'll show you a picture. You saw this in lab. Okay, so you can see here, this is a spinal nerve here. Okay. You can see where it's connecting to the spinal cord here. So those are our roots. Okay. Or those rootlets. The ventral roots, those are going to come from the anterior horn. And the anterior horn, remember, what do I call it? The anterior motor horn. So the ventral roots, because they're coming from the anterior horn, they carry motor fibers, efferent fibers. Remember, E for exit. The dorsal roots, those are coming from the dorsal horn, and so they are carrying sensory fibers. Remember, A for approach, sending information back towards the brain. So let's look at this picture and kind of talk about what I mean here. All right, so I told you that the spinal nerves, which are here and here, you can see the spinal nerve, those do both, right? I'll put a B in there. They're carrying both sensory and motor, right? And that's because coming from the front, coming from these ventral roots, this is all motor information, okay? And back here, coming from these dorsal roots, this is all sensory information. When they merge together to make that spinal nerve, now it's both, okay? So we have motor in the front, sensory in the back. We merge them together to make a spinal nerve that now has both motor and sensory. Oh, I think I missed a few on that slide. Nope, I found it all. So our spinal nerves, like I mentioned, are here. And on the model that you looked at in lab, that's where your model ends, right? It shows the roots, and then it shows where they converge to form the spinal nerve. In reality, that spinal nerve is not very long. That spinal nerve is going to branch. You can see it branching right here. Okay, so it branches again. And those are called rami. So let me show you on that model, which I looked at last week. So your models don't show the rami. Your models just show the roots, right? So you can see the anterior and the posterior roots, and then you can see here where they come together to form the spinal nerve. The spinal nerve is not very long because once we get a little farther out, it branches again into rami, right? But once you've formed a spinal nerve, it's mixed. It carries both sensory and motor. So that means when you branch it again into rami, those are also mixed. Okay? So rami are basically branches of the spinal nerves. And so we have rami that branch towards the front of the body and towards the back of the body. The ones that go towards the back of the body, so you can see them here. Here's the dorsal ramus, and here is that dorsal ramus. You see it going towards the back. Those are smaller. They're not as thick. And so those are going to supply the posterior trunk of the body. So they're basically going to the trunk. The ventral ramus, which is this branch here, those are thicker, they're fatter, and those are going to supply the front of the trunk and the arms and legs. And so that's why it's fatter. Okay, so this is why that ventral ramus is a little bit bigger, because it's going to more places, right? It's going to go to the front of the trunk and the arms and the legs. And again, remember, these are also carrying both sensory and motor. Okay? Once you form that spinal nerve, you can't separate sensory and motor anymore. It's all mixed from here on out. And so that also brings us into a plexus. Now again, you looked at a nerve plexus on that flat man model, right? What is a plexus? Going where?
Away.
To where?
A limb.
A limb, right? So a plexus is a group of nerves going to a limb, right? Arms or legs. So let's see what this first bullet says. It says, all ventral rami, except T1 through T12, form a plexus. So I'm going to break this down. So first it says ventral rami. Why are only the ventral rami part of a plexus? Why are only those forming a plexus? Because why? Remember, they're both. They're sensory and motor. So remember, here's the dorsal ramus, and I told you only ventral rami form a plexus. Where do ventral rami go? The front of the trunk and the limbs. And think about what a plexus is, a group of nerves going to the limb. Okay? Dorsal rami cannot form a plexus because they don't go to limbs, right? The dorsal rami only supplies the back trunk of the body. Okay? So only ventral rami will form a plexus. And then it says all your ventral rami except the ones in the thoracic region. How come none in the thoracic region form a plexus? Because there's no limbs in here. We already did this one in lab. You have no limbs in the thoracic region. And so because of that, all those nerves are not forming a plexus. So we find plexuses in the cervical and the brachial region. Okay, these are going to go to the arms. And the lumbar and the sacral regions, these are going to go to the legs. So remember, a plexus is a group of nerves going to a limb. So you don't have just one nerve going to your arm. You have a whole group of nerves going down into your arm. This is really important because if you damage one spinal nerve, like let's say you have a herniated disc here, and it's on the right side and it's pinching that one spinal nerve. Maybe it's pinching like C6, which goes down into your arm. And so that one spinal nerve, C6, going into your right arm cannot function anymore because it's being pinched. Do you lose all control of your right arm, or can you still move it? You can still move it because you've got C4, you've got C3, you've got C7 and C8 all going into your arm. And even T1 goes into your arm. So you've got all these other nerves supplying your arm. Now you're going to feel it in your arm. It's going to feel like numbness and tingling, but you can still move your limbs. So this is why this is really good to have a plexus. Okay. So we're going to go through the cervical, the brachial, the lumbar, and the sacral plexus. Okay, so the cervical plexus is the highest one. So this one is C1 through C4. Most of the nerves coming from the cervical plexus are going to hit the neck, the ears, the back of the head, kind of down into your shoulders. They'll hit like your deltoid muscles, okay, the upper part of your arms. There is one nerve that's really important in the cervical plexus called the phrenic nerve. The phrenic nerve is the major nerve of your diaphragm. So this one helps with breathing. So this is why, like Christopher Reeves, so y'all remember he was in that horse accident. I think he got trampled by a horse and severed his spinal cord way up in the top, like cervical regions, like C1 or C2. And so he was quadriplegic. He couldn't move or feel anything below that site, right? But remember, his internal organs still worked because of the vagus nerve. However, if you ever saw Christopher Reeves in an interview, he had that, what's that called? He had why can I not think of it? He had the device that helps him breathe. He could still talk around it, but it went into his trachea and it kind of helped to fill his lungs up. He needed a little extra help. I cannot think of what that is called.
Is it a trachea?
Not a trachea. It was like a ventilator, but it was, he could still function.
Let's Google it.
A what?
I said, let's
Google it for me. That. He had that, whatever that was. And so if you ever saw him in an interview, you would see like he would get some help with his breathing. And the reason is because of the phrenic nerve. Because the phrenic nerve, where it comes off in the cervical plexus, if you sever your spinal cord above that, your diaphragm doesn't work anymore. Even though your lungs still work and even though everything else still works, if your diaphragm's not working, you need help expanding your lungs in and out. You need help with that. Okay? So this says if both phrenic nerves are severed or C3 to C5 of the spinal cord is crushed, then your diaphragm is paralyzed. And you can still function, you can still survive, you'd be a quadriplegic, but you would need help breathing. Did you find it?
It's called a ventilator.
A ventilator? I thought it would be a special type of ventilator. Because it's not like what they don't put like the, maybe it's because the tube doesn't go down your mouth. It goes,
Reed described it as hospital ventilator.
it's not important. Y'all know what I'm talking about, right?
Yeah.
All right. So this is showing you the cervical plexus here. And I don't really like this picture, but this one, dipping straight down, that's the phrenic nerve. So that's the one going down to the diaphragm. The brachial plexus is a little bit lower. Okay, brachial means arms. So this one is definitely going to go into the arms. This goes from C5 to T1. Sometimes the brachial plexus is a little bigger, like from C4 to T2. Okay, so the range is a little bigger. But there's a lot of really important nerves in the brachial plexus. Nerves like the axillary nerve. The axillary nerve, where's the axillary region? Armpit, right? So the axillary nerve is going to hit like the deltoid. It's going to hit a lot of the rotator cuff muscles, like the supraspinatus and the infraspinatus muscles. The musculocutaneous nerve, this one's going to go to your bicep, your brachialis muscle, and down into that forearm. The median nerve is going to go to the flexor muscles of your palm and your forearm. So this is the one that when I showed you a muscle twitch, I stimulated my median nerve. It's right in the middle. If you look at your wrist, those two tendons right in there, the median nerve just runs right in between those. And it's a flexor. It controls a lot of those flexor muscles. That's why when I showed you the twitch, you saw my thumb flexing. Okay. Now the ulnar nerve, this is one that kind of wraps around the ulna, and it's going to hit any flexor muscles that the median nerve does not get. This is also sometimes called your funny bone. You know when you hit your elbow and it hurts, there's nothing funny about it. It hurts really bad. You're not hitting a bone. We call it the funny bone, but it's not a bone. The ulnar nerve is very superficial where it wraps around your elbow. So when you hit it and it hurts, you've actually hit the nerve. That's why you have that really sharp, horrible pain. And then the radial nerve. The radial nerve, this is going to be an extensor muscle. So this is going to hit all the muscles on the other side to help extend back out. So here's a picture from your book, and this one is showing just the axillary nerve is what they have blocked off up here. You can see it's the green one going around the armpit. But some of the other ones, like this yellow one right here, that's the median nerve. You can see it running right down the middle, flexor one. Here's the ulnar nerve, and now you can kind of see what I'm talking about. See how it wraps right around that elbow, right around the ulna? That's why we call it the funny bone. If you hit it, it's very superficial right here. And this one's going to hit any flexor muscles the median nerve doesn't get. And then this one in green here, this is the radial nerve. You can see that it goes and crosses, and it's going to go on the other side to pick up extensor muscles. Now we're going to move a little lower into the lumbar region. Now the lumbar plexus comes from L1 to L4. And the lumbar plexus is going to go to the front of the body, in the legs. So it's going to hit your thighs, the front of your thighs. It's also going to hit your abdominal wall. Okay, so it's going from the abdomen all the way down the front of the legs. So I'm going to write this down. Front of legs. The major nerves of your lumbar plexus are the femoral nerve. This one's going to go to the quadriceps, the anterior thigh, and the obturator, which hits some of those adductor muscles kind of on the inside of your leg. So you can see this picture. When you look at this picture of the lumbar plexus, notice that, again, you're looking at the front of the body, right? If you look at the feet, you can tell the way the feet are positioned. You're looking at the front. It's going to the abdomen, front of the legs. Sacral plexus. This is lower. It's coming from the sacrum, so somewhere between L4 and S4. This is going to hit the back of your body. It's going to hit your gluteal muscles. It's going to hit your hamstrings, all down the back of your legs. So I'll write that down, back of legs. And the major nerve in the sacral plexus is the sciatic nerve. It's actually the longest, thickest nerve in the body. It's actually two nerves in one. The two nerves are the tibial and the common fibular nerve. So I'll show you a picture. Again, you can tell you're looking at the back of the body, because again, look at the feet. You can tell, looking at the back based on how the feet are positioned. So we can see this is going to hit, the sacral plexus is going to hit down in the gluteal region and all the way down the back of the legs. This big fat one right here, that is the sciatic nerve. Once you get to the back of the knee, it branches into the tibial, running down the tibia, and the common fibular, running down the fibula. Okay. Now there is a condition called sciatica. You hear old people like, oh, my sciatica is acting up. Sciatica is when the sciatic nerve becomes inflamed or aggravated. So the pain that you're going to feel is going to be sharp shooting pain that runs down the backs of your legs. Sometimes it's into your gluteal muscles. Sometimes it'll run all the way down the back of your legs. If you think about those muscles help with pointing the foot, right? They help with lifting the leg, right? Flexing the leg. That's going to be all from the back. And so a lot of times people will experience some weakness on the back of the legs because of it. It's not uncommon for women when they're pregnant, if they're carrying multiples, or if they have a really big baby, if it's sitting funny, it can sit on that sciatic nerve and they can have sciatica for part of their pregnancy. It'll go away as soon as the baby is born, but it is not uncommon. The last thing I want to walk you through is dermatomes. And I like that they're kind of right here, right after we've done nerve plexuses, because they follow a nerve plexus. A dermatome is just skin that's innervated by spinal nerves to give you sensation from that area. All of your spinal nerves except C1 participate in dermatomes, so they help you pick up sensation in all your areas of your skin on your body. This one I think is easy to remember because derma means skin, right? So a dermatome. This is a picture showing you dermatomes, and they're all color-coded here. So you can see from C2 to C5, and even down into T1, these are going to the head, the neck, and down into the arms. That happens to coincide with the cervical and the brachial plexus, right? They happen to go in the same exact place. The thoracic spinal nerves from T2 to T12, notice they're not going out into the arms or legs because you have no plexuses there. So the dermatomes supplied are basically the trunk, front and back of the trunk. Front of the legs, notice all of these have an L on them. Remember the lumbar plexus goes to the front of the legs. So this is going to pick up sensation in the front. Flip the body around and now this pink color, these are all of our sacral nerves. The sacral plexus goes to the back of the body. So dermatomes follow the plexuses, and it's just picking up sensation in the skin. Okay. So based on, let's say there's an area in your leg, or maybe there's an area, we'd say in your leg, where you kind of can't feel like the whole top of your foot and your shin right here. Well, doctors might suspect that you might have an issue with L5. You might have an issue with that spinal nerve, that L5 spinal nerve. Now the last thing I'll mention in this chapter is a little bit on reflexes, and we talked about these in chapter 12. This is sort of a predictable motor response to a stimulus. So a reflex can be inborn, we call this intrinsic, or it can be learned or acquired. Usually these involve your peripheral nerves, your spinal cord, and the brain. So all of your nervous system, peripheral and central, are usually involved in a reflex. A lot of times, when we talked about the central nervous system, I told you that the brain is the integration, the command center. For a reflex, sometimes the spinal cord can be the integration center, because reflexes are quick, right? So sometimes the spinal cord is integrating that information and sending the reflex back out. Now, when this says that a reflex can be inborn, an inborn reflex, an example would be the pain withdrawal reflex. You touch a hot stove, you jerk your hand away, you withdraw from pain. We see that in infants. Infants will withdraw from pain. So this is an inborn reflex. Right? an acquired or a learned reflex, it's really hard for us to tease these two apart. So the best example that I have would be like, if I'm boiling a pot of water on the stove, I'm getting ready to make spaghetti. And I'm boiling this big pot of water and the pot tips over towards me. My withdrawal reflex would say, jump out of the way, get out of the way so that I don't get hurt, right? But if I'm boiling that big pot of water, sorry, that would be intrinsic. But if I'm boiling that big pot of water and my 7-year-old son is helping and the pot tips over, instead of me jumping away, I would probably jump in front of him, right? So that would be more of an acquired reflex. It's a learned reflex, and it's just your situations have changed how you react to circumstances. So you can change your reflexes based on experiences. So that's more of a learned or an acquired reflex. Again, it's kind of hard to tease the two apart. That's the best example I can give you. A reflex arc is just how the information travels in your body. I think you all already know this. A reflex arc means that you have a receptor which is going to pick up the stimulus. So you touch a hot stove, the receptor are going to be temperature receptors in your hands. A sensory neuron is going to send that information up spinal nerves into the spinal cord. And the spinal cord or the brain will integrate the information, and it will send motor information back out to your muscles, going out through your spinal nerves into all of these muscles of your arm so you can jerk your hand away. All right, so we would say those muscles would be the effector, something that's going to move or respond to the impulse. So that's our reflex arc. And so all of the reflexes that we have in the body, they're either somatic or autonomic. Now you've heard these terms before. Remember, autonomic means automatic, involuntary. Somatic is voluntary. Where have you heard these before? Back in chapter 11, remember we talked about divisions of the nervous system? And remember we have the somatic and the autonomic division of the peripheral nervous system. Somatic means that it's going to skeletal muscle, it's voluntary. Autonomic means that it's going to things you have no control over, like your heart rate and your blood pressure and whether your sweat glands start producing sweat. These are all things you have no control over. So a reflex can be either somatic, meaning it activates your skeletal muscle, like that patellar tendon reflex, and you jerk. That's activating skeletal muscles. Or it can be autonomic. It'll activate visceral effectors. So that might be where you get hot and you start sweating. That is a reflex for when you're hot. You are cooling yourself back off, maintaining homeostasis. I'm not going to talk a lot about autonomic reflexes. We'll spend a couple more minutes on spinal reflexes, somatic reflexes. Again, anytime it's mediated by the spinal cord, if that becomes the integration center, we call these spinal reflexes. They're quick. And we test spinal reflexes just to make sure your nervous system's functioning okay. If a reflex is exaggerated, right? If they do the patellar tendon reflex and your movement is crazy and super wild, they might go, there's a problem. Or if it's distorted, like if they hit the right knee and the left knee jumps, there's a problem. Or if it's absent, if they hit it and nothing happens, right? This is how my husband was diagnosed with his condition. The one reflex, now I mentioned to you at the start of this chapter, there's a whole bunch of reflexes in your book. I'm just doing this one. This one is called the plantar reflex. This is one that we see in the feet. This is one that we do in babies when babies are first born. They will take something like a tongue depressor or a probe, okay, and they will run it down the lateral aspect of the foot. So the sole of the foot, they would run it down from the pinky toe down to the heel. Okay? In a baby, when you do the plantar, when you run something from the pinky toe to the heel, the plantar reflex, the normal reflex, is downward flexion of the toes. So it is natural when you do this in a baby that the toes flex, okay, they curl. That's what we want to see. If there's an abnormal reflex, we call it Babinski's sign. This is when you run from pinky toe to heel, and instead of the toes flexing, they fan out. And that indicates corticospinal damage in an infant. So this is something they do in all newborn babies. They'll do the plantar reflex. Okay? And again, like I mentioned, there's a whole bunch of other reflexes in here. And I may ask you one as a bonus question, so you may just want to look over those. None of them are super difficult. They're just different kinds of reflexes that we have in the body. Okay? Y'all have any questions on chapter 13?